Hello, I'm Lee-Fay and I'm here to talk to you about post-diagnostic supports for people with dementia. In the last 30 years, researchers have increasingly focused on detecting dementia earlier. There's been a proliferation of research on MCI, mild cognitive impairment. The development of PIB imaging meant we were able to detect A-beta in brains of living people well before symptom onset. And many of you might be familiar with this figure by Jack Jr., which shows how we've been thinking about detecting and treating Alzheimer's disease earlier and earlier. Parallel with this, dementia policy and public information campaigns around dementia have also had a focus on increasing diagnosis and decreasing stigma. Australia's national frameworks for action on dementia included priorities for increasing timely diagnosis, and we think that the new framework will continue to have this emphasis. Dementia Australia has campaigned quite successfully to increase awareness around dementia. They've been showing people with dementia as regular people we can relate to, who can live well in order to decrease stigma. As psychosocial researchers have also been developing the evidence for treatments that can improve the lives of people with dementia after diagnosis. I like to think of these treatments as rehabilitative treatments, using the broad definition of rehabilitation as given by the WHO. While I don't have time to review all the evidence for rehab treatments, these are summarized nicely in our book. We know that medications, behavioral strategies, carer programs, cognitive interventions such as CST, exercise, and occupational therapy can improve outcomes. And we're still doing more research on psychological therapies, peer support, and speech pathology. I suspect that we're diagnosing some people with dementia earlier than we were 30 years ago, but we don't really have data about this. An issue that has emerged in the last decade is that people with dementia aren't getting appropriate information, treatment, and services after diagnosis. Kate Swaffer was the first person with dementia I heard speak publicly about this. She was told to give up work, give up study, get your end-of-life affairs in order, and get acquainted with aged care. She called this treatment prescribed disengagement. The Royal Commission for Quality and Safety in Aged Care also reflected the need for better post-diagnostic support for people with dementia. So I'm here to tell you about two of our research projects where we've been working towards this better post-diagnostic support. First, I'm going to tell you about some of the problems with the post-diagnostic support received by Australians with dementia. Cognizance is our 5-country collaboration. The countries were Australia, the UK, Poland, Netherlands, and Canada. All 5 countries ran focus groups and surveys. We started before the pandemic and finished in the first few months of it, so most of our data collection was online. And we included people with dementia and carers diagnosed in the last 2 years and the clinicians who support them. This slide shows participants in our surveys and focus groups. Our participants were predominantly white, they had high SES, they were digitally literate. They were probably more capable of getting post-diagnostic support than other people we didn't even manage to recruit into this study. These are the post-diagnostic experiences of Australians. Less than half had received a care plan. Less than half said they got sufficient information about managing dementia. Less than a third were confident in asking for professional help. And less than a third were confident about living positively with dementia. You can see the data for people with dementia in yellow and for carers in red. While I'm not showing you the data, relative to the other countries, Australians were more dissatisfied with the post-diagnostic supports they got. Clinicians told us that less than 20% often or always provide a care plan. About a third were satisfied with linkages to post-diagnostic services. More than half were satisfied with the post-diagnostic support in their region, and over 70% said that they felt that they personally had received adequate training in post-diagnostic support. And we often remarked, I guess, on the difference in what clinicians told us to what people with dementia and carers were telling us. Of course, acknowledging that these are both select, non-representative samples. From our qualitative data, here are the key themes we heard. People with dementia and carers told us that they had very strong emotional reactions when told the diagnosis. They said this was devastating. They felt shock and confusion, grief, loss, fear, anxiety, worry. For some, there was disbelief and uncertainty, denial. For some, there was relief because they finally had an explanation for the symptoms. I was shocked, like numb. My thoughts weren't going anywhere other than absolute uncertainty. All but one person was not satisfied with the post-diagnostic support they received. They said it was like staring into a void. They were left to fend for themselves. They said, it feels like we're drifting out to sea. What do I do now? What do we do now? Care partners particularly felt that all the responsibility felt to them. They felt blame, they felt desperation. This is the model of ideal post-diagnostic support that people with dementia and carers told us they wanted. I think core to this is this need for a one-stop shop, for one person or one organization they can keep returning to for emotional support, information, navigation, for a care plan. This place gives them information tailored to the time, to where they're at that moment, in acceptance and their personal needs. They needed to trust it. It needed to be quality. They wanted this one-stop shop to provide personalized referrals to other services. You can see all the other services around there, but they didn't want to tell their story to each service, each person they talked to. It was also important that that one-stop shop was local and provided local information, and that they could return to it. It was a recurring service. They could return to it whenever something came up, when they had a question or a crisis. Diagnosticians told us it was a difficult conversation, telling someone they had dementia. It was particularly uncomfortable when the person was younger than them, when they had young onset dementia. And our clinicians stressed how important follow-up and a positive narrative is. Clinicians also talked about how the system is a challenge. They talked about inadequate resourcing and funding for post-diagnostic services. They found it hard staying up to date with what local services were available, and they particularly found getting aged care difficult and complained about MAC. They wanted a key worker to navigate and coordinate information and services after diagnosis. And they talked about the disconnect between diagnostic services and post-diagnostic services. After hearing from people with dementia, carers and clinicians about problems with the post-diagnostic support system, we decided we really need to look at the system some more. Our aim was to determine current practices and develop an ideal shared dementia pathway for Australia. This project's called Dementia Together, and we were using a modified Delphi process to develop the pathway. Here is what we did. We started by reviewing the various national and international pathways for dementia, and we also looked at pathways for other chronic diseases. We already had good data from Cognizance and other studies about the needs of people with dementia and carers, so we focused our interviews on policymakers and clinicians across the range of services that supported people with dementia, and also from all the states and territories. Based on these interviews, our team drafted dementia pathways, and we got feedback on these pathways through a set of surveys. Any items which are contentious, which we didn't have very high agreement on in the surveys, we took to an expert panel group who gave us more feedback. A key theme from the interviews was that there were dispersed and sometimes unclear responsibilities for coordinating dementia supports and services. Aged care was really clearly a federal responsibility, but aged care services did not take responsibility for detecting or diagnosing dementia or for coordinating medical care. Specialist diagnosis and management is a state responsibility, but many clinicians told us about silos within health as well. Dementia Australia services were generally praised, but they do not routinely coordinate or talk to other services. And often people with dementia and carers took a long time to get to Dementia Australia, if they got their services at all. We were struck by how the services really varied around the country. For example, there were much fewer services in regional areas. They were much harder to access. And services are delivered by many small, medium, and large organizations. Kind of imagine this patchwork of services, which is patchier in some areas, and it really depended on the initiative, goodwill, passion of clinicians and services in the area, how well those services ran. Many clinicians talked about the importance of relationships in an integrated or joined up care pathway. Sometimes the relationships they described were really personal, so they happened to know a clinician in another local service. There were less examples of systemic relationships set up between services, where it didn't matter whether someone left or not, that relationship between the services would continue. There were many missing relationships in the pathway, such as between primary care and aged care. It appeared that GPs were the default service for starting the diagnostic process and for managing dementia after diagnosis, for dementia post-diagnostic support. However, there were also many concerns about the attitudes, skills, remuneration, and capacity of GPs and practice nurses to fulfill these responsibilities. This is a big problem for our pathway. And dementia stigma was also mentioned as a barrier. People with dementia and carers sometimes denied the symptoms, rejected the diagnosis. They wouldn't seek help because they didn't really want to acknowledge that they had dementia. GPs and other clinicians had therapeutic nihilism. They thought that there was little that can be done. There's no point in giving someone a diagnosis. These are some of the results from the Delphi study, showing just the opinions of the professionals here. There was really high 90% agreement that ideally the primary care team should coordinate medical management. That's the pink lines. But this usually always happened less than 30% of the time. There was slightly less agreement about who should coordinate all services and support after diagnosis. It was still high, 77% agreement. And this usually always happened very rarely, about 5% of the time. Our expert panel told us that they didn't actually think that primary care should do coordination of services and supports more generally after diagnosis, which really begged the question, well, who should do it? Because there is no current service in the system that coordinates medical, aged care, and other services after diagnosis. This graph shows the difference between ideal practice in pink and sometimes usual always practice at the moment in grey, in terms of referrals made by the primary care team after diagnosis. There was generally very high agreement or high agreement that these referrals should happen. The referrals in practice were made less than half the time, except for referrals to my aged care. Our survey and expert panel respondents told us about major barriers to implementing this pathway. Firstly, there were limited GP and practice nurse skills and knowledge around treatments and services after diagnosis. There's no primary care funding for cross-sector coordination or for the amount of post-diagnostic supports that people with dementia might need. There's no systemic structure for case discussion, information sharing between systems about patients. And there's no service responsible for care coordination across services. After hearing the problems with the system and how hard it's going to be to implement a post-diagnostic support pathway that's shared and integrated, I wanted to just throw my head in my hands and go, what can we do? So we have a few small offerings, the beginnings of trying to improve things in the system. The first is called Forward with Dementia. This is our Forward with Dementia website, the website and campaign that our Cognizance collaboration co-designed with people with dementia, carers and clinicians. As you can see, the resources are written for 5 different countries and in 4 different languages. I'm going to take you to our Australian site. Each website has 3 sections, one for people with dementia, one for carers, and one for healthcare professionals. It's relatively uncommon to have a whole set of resources specifically for people with dementia. Let me go to the news and stories pages. First, stories. We were told by our co-design groups that it was really important that we included stories from people with dementia. For example, here's Dennis Frost's story where he talks about how he felt when he received his diagnosis of frontotemporal dementia. As appropriate, we link from each story to different informational pages on the website. We also have a news page, for example, one that Professor Brodati wrote on aducanumab, and we highlight different relevant research and other projects in this section. The core content on this page is in the information page, and here you can see the main menu for people with dementia. We've kept the language positive but realistic through the website, and we've emphasized taking action rather than passively receiving information. I'll take you to the supporting well-being page, where you can see that we've incorporated the evidence around rehabilitative strategies in this information. And while we weren't able to produce a searchable directory of local services, which is what people said we wanted, we do provide information about how to access different services. On the healthcare professionals page, which is relatively short, we have some videos and resources about how to tell someone they have dementia. And we also have tools and resources for your clinic, such as a diagnosis consultation checklist, patient information resources, and FAQs for patient and families. You can also download or order a flyer or poster for your clinic if you want to share information about our website. We'd love you to share this with your patients. I'm also really excited to show you the draft of our Dementia Pathways for Australia. It has the primary team instigating explorations irrespective of where the referral comes from. The GP either making a diagnosis, making a referral to a medical specialist for the diagnosis, or consulting with a dementia specialist such as a dementia CNC or a medical specialist in order to make the diagnosis. The diagnosis might be given by the GP, or they might refer to another specialist for management and advice. After diagnosis, the pathway has a whole host of different people involved, including the medical specialists who might continue to follow up the person, dementia specialist input. This might be the older person's mental health team or a dementia CNC. There might be allied health practitioners, either private ones or who work in community mental health. There will almost certainly at some stage be aged care or disability services and other services such as Dementia Australia or DB Mass. We've tried to show that primary care is responsible for health-related management and support, and there needs to be two-way communication between the primary care team and these services. We've also indicated that ideally one service should have responsibility for coordinating health and non-health services. So what should we be doing next to fix the system? Remember the void I was telling you about? This kind of nothingness that people with dementia and carers talked about after the diagnosis? I've been thinking, how do we help people cross the void? We can't just expect them to jump across themselves. I don't think that the pathway, our map, which just tells you where you can go and who should see who next, is enough. We'll definitely need to implement that map. And a navigator who will step-by-step guide people through services, I don't think that's enough, because you can only navigate if there's services to navigate people to. So what we need to do is build this system of post-diagnostic support. We need services that are easy to access and consistent across the country. We need these different services to have both a data infrastructure and a culture of collaborating and information sharing. For people with dementia who can't navigate the system themselves, we need someone to hold their hand and help them work through the system. A case manager or care coordinator. It's more than getting the services. It's making sure that those services keep talking to each other and know, so that the right hand knows what the left hand and the left foot is doing. And that's really what we need for a proper, joined up, shared care system of post-diagnostic support. So as we build these stepping stones for a better system of post-diagnostic care, we need to involve everyone in this. Critical are policymakers, people with dementia carers. We need to influence diagnosticians. GPs and practice nurses have emerged in our research as really critical to post-diagnostic support. But we also need to train allied health practitioners, people who work in aged care. They're all part of the system. I'd like to thank my many, many collaborators. Thank you for listening. I look forward to continuing this conversation.